Hello everybody, my name is Dr. Thomas and I'm from STARMED Medical Education, and I'll be doing an ACT tutorial on how to approach a patient with cough or pneumonia. So let's begin. To start with, I'm going to talk about what is the overview of the clinical encounter and what are you expected during each NACS stations. So an NACS station is divided into three phases. One is the pre-encounter, encounter, and post-encounter, right? So during pre-encounter, there is something called a doorway information that will be provided to you at the door. So you should go through the doorway information, which may include the name of the patient, the age, the sex, the complaint that the patient has come up with, and it might have some vital signs for you to take a note of. Okay. So as you go through the doorway information, you'll hear a bell. So the doorway information, you'll be given 2 minutes to look into it. As soon as you hear a bell, you should enter the room, knock on the door, and enter the room. I'll be talking in detail about how to approach a patient in encounter phase. So as soon as you get inside the room, you'll be given the encounter phase will be 11 minutes, depending if you have any oral question station or not. So 11 minutes, it could be just history taking, or it could be a conversation with history and physical, or it could be just counseling station or history and counseling, anything, right? So if there is a station with oral questions, it would be written on the doorway that the station has oral question as well. So oral question would be asked by the examiner, and they would be given 3 minutes to ask you question. So as soon as you're done with the 8-minute approach, you have to turn to the examiner for them to ask you questions for the next 3 minutes. And whatever they say, so you should so each doorway information will tell you whether it's an oral question station or not. Okay, so if it's oral question station, after 8 minutes of your task, you should turn to the examiner for them to ask you a question. And whenever the examiner will tell you, okay, I'm gonna ask you 3 questions, I'm gonna ask you 4 questions in the next 3 minutes, you should hear them properly, give attention to what they're saying, because you might not know how many questions he's going to ask and you will not have sufficient amount of time to answer those questions. So you should listen to him, like whether he's saying 3 questions, whether he's saying 4 questions, and you should divide your last 3 minutes according to that. Okay, and after that so that's all about the overview of the clinical encounter. So next, let's, like in the previous slide I told you, there is you have to take a detailed history and do a physical examination. Sometimes you would just think it's a history station and you forget to do physical, right? So you should understand the task, list if there's any specific task that you have to do. Okay, for the above, you see the case scenario on your doorway, you have to first understand the task, right? By understanding the task, what I mean is you should see the name of the patient, what is the age, what complaint they have come with. As soon as you see the complaint, you should list your differential diagnosis list, right? You should have at least 5 to 10 differential diagnoses in your hand for you to ask questions, right? You can write down your history format so that you don't forget anything, and you should note down any specific task that has to be performed. Like in the previous slide, um, case scenario, let's list the differentials. Okay, so if it is an acute cough less than 1 month, it could be a pneumonia, it could be COPD, it could be pulmonary aspiration, anaphylaxis, or pulmonary embolism. If it is subacute is 1 month to 3 months or 4 months. It could be bronchitis, viral upper respiratory tract infection. It could be pertussis, asthma, or GERD. If it is a chronic cough, it could be asthma, or tuberculosis, congestive heart failure, or a malignancy. So once you have a set of differentials, it becomes easy for you to ask questions, right? So you should have the list of differential diagnosis. Now let's enter the encounter phase. During encounter phase, what are you supposed to do? First thing, you knock on the door. As you enter, wash your hands and sanitize yourself, verify the patient's name and age, introduce yourself and shake hands, and find out why the patient is at the clinic. So as you enter, you should be like, hey, Mr. Smith, I'm Dr. Thomas, and I'm the duty doctor today, and how can I help you, right? So you can just confirm like why the patient is here, and you can just start your encounter phase. Okay, encounter phase, like I told you, history taking, right? So you'll be starting with the history, right? So history of presenting illness. So any disease, any condition, you have to ask about the OCD, that is onset, course, and duration. When did it start? How did it start? How often do you cough, right? During what time of the cough is more? Do you bring out any phlegm with the cough, or is it dry? One more thing that you have to note down, if there's any discharge, you should ask about coca plus minus B. That's nothing but the color, the odor, the consistency, the amount, whether it's a teaspoon, tablespoon, or a cupful, or was there any blood associated with? Did you see any blood in your cough, right? And does anything make it better? Does anything make it worse, right? Then you can ask about the associated symptoms, that is the constitutional symptoms. Did you have any fever? Did you have any chills? Are you experiencing any chest pain? Do you get short of breath? So whenever it comes to questioning the patient, make sure you ask one symptom at a time. Okay, that's very important. uh, because if you ask multiple questions at a time, like, do you have fever, chills, or chest pain, the patient will just answer you for chest pain, and you just, I mean, yeah, the patient will just forget about fever and chills, right? So every time, to take adequate information from the patient, be specific in your question. Okay. Do you get short of breath? Have you noticed any change in your weight? Do you feel nauseated? And the next question should be, did you vomit? Okay. How is your appetite? Is there any change in your bowel habits? Did you notice any bumps or lumps in your body? Have you noticed any night sweats? So these constitutional symptoms, right? This is a standardized for all cases, whether it is cough, whether it is chest pain, whether it is just headache. You have to ask all these constitutional symptoms. Okay. Next, you can ask about the travel history. Have you traveled recently? Past medical history. This is very, very important. You should ask about if they had any respiratory disease, if they have any underlying condition like diabetes, are they pregnant, if they have any other conditions, right? Because if, like, I'll be just covering ahead, so I mean I'll be just covering in my later slides. There's something called immunosuppression pneumonia that happens if the patient is already is immunosuppressant. They are more prone for immunosuppressed pneumonia, right? So you should ask about any underlying disease if they have. Then you can ask about the drugs, right? Which medication? You can split this into past medical history, medication history, or drug history, right? Are there any drugs, like for example ACE inhibitors can cause cough, right? So you should ask about that. And if they are already asthmatics, what medication they are on, are they using their inhalers, how many times do they use it in a day? So you can ask about all those things. Was there any history of hospitalization? Is this the first time you're having chest infection, or before, like during before in the past, did you have any chest infection? You can ask all that. You can ask about the immunization status, like are they vaccinated for pneumococcal or influenza? You can ask about all those things. Okay. um, Coming on to the family history, you should ask about if any respiratory disease that's running in the family, like cystic fibrosis, asthma, alpha-1 antitrypsin deficiency. These are more specific to respiratory disease, but you can even ask about a history of diabetes or hypertension that is running in your family. Okay. Social history will basically be confined to, you can ask about like how many people live, do you live alone, right? What do you do for daily living, what is your occupation? You can ask about your occupation here. Then you can ask about, you can again divide this into social history and personal history, and in that you can ask about smoking. uh, do you smoke, do you drink alcohol, do you use any recreational drug? So you can ask about all these things. How many times do you smoke? How many packs of cigarette do you smoke, right? Are you planning to quit? So whatever, you have to ask all that in social history. Okay. Next, So that's all about the history taking. Let's just come on to the physical examination. Okay, so physical examination, let's start with the general examination. So general examination, the first most thing is vitals. You should either take the vitals, blood pressure, pulse rate, feel for the pulse, or if the vitals were given, you can just comment on that. These are the vitals of the patient. Okay, and how does a patient look? Do they look toxic? That means, is he like stooping and gasping for air? Is he in distress? You can comment on that. So in NACOSCE, whatever you are gonna do on the patient, you should tell what are you doing, what are you looking for. Okay, so if I'm seeing the general appearance, you should tell very loudly, I'm looking for general appearance of the patient. The patient doesn't look in distress, or the patient looks in distress. Okay, then you can check if there's any pursed lip breathing, any clubbing, cyanosis, any nicotine staining, tremors, is there any edema in your legs. So you can comment on all those aspects in general examination. Okay, next, after you're done with the general examination, you can comment on the, you can do the hint examination, that is head, eyes, ears, nose, throat, and neck. So basically in respiratory conditions, you should mainly focus on the nose, throat, and neck examination. So nose, you can inspect for any nasal polyps or nasal bugginess. In throat, you can look for any oropharyngeal erythema. But is there any tonsillar hypertrophy? Can you see any exudate? So you should comment on all that. So once you're looking into the throat, you should tell the patient, okay, I'm gonna look at your throat, and I'm looking. Then once you're looking, you can say, I'm looking for oropharyngeal erythema. I can't see any oropharyngeal erythema. There is no tonsillar hypertrophy. There is no exudate. So whatever you are doing, tell the patient what you're doing, and tell what are you looking for. Okay, and comment on your findings as well. So 3 things. Okay. Um, Next is respiratory system examination. The first thing is inspection. You have to look for any deformity. If it is pectus excavatum, carnatum, barrel shaped, you can just look on inspection. You should comment. There is no deformity, or there is deformity, there is barrel shaped chest. Then you have to comment on the scars, the type of breathing. So you can tell, I am inspecting for the type of breathing. I'm looking for the movement of chest. Okay, any skin lesions. Even in respiratory, you can look for a back speed, or you can do that in your cardiovascular system as well. Okay, once you're done with the inspection part, you can move on to the palpation, right? So during palpation, what do you see? You should first of all, and the most important is, you should palpate for the trachea, whether it is centrally located or whether it is deviated, right? You can look for the chest expansion. So just put your hands around the chest and ask the patient to breathe in, breathe out, and look for the chest expansion. So it could be symmetrical or asymmetrical. Whatever is your finding, comment on that. Say, I'm doing the chest expansion and I can see that it's moving symmetrically. So there is symmetrical chest expansion. You can palpate for the back speed, tactile vocal formators, and you can palpate the ribs. If there's any trauma, history of trauma, you can look for any localized pain that would suggest rib fracture, or sometimes progressed coughing, prolonged coughing, or severe coughing can result in rib fractures. So you can palpate for that. During percussion, you should percuss the chest and see whether it is a resonant note, if it is symmetrical on both sides, are you hearing any dull note, right? So, and when you're percussing the chest, you should also percuss for liver dullness and cardiac dullness. During liver dullness, if it is resonant below the level of the liver, it could be sign of hyperinflation, right? So you should always check for liver dullness. And even cardiac dullness, if the cardiac dullness is decreased, it could be emphysema or asthma, right? Auscultation, wherever you percuss, you should put your stethoscope and do auscultation. Okay, you should hear for the breath sounds. You should ask the patient to take deep breaths through the mouth and comment on the breath sounds, whether it is vesicular or whether you can hear bronchial breath sounds. Did you hear any added breath sounds? What type of added breath sounds did you hear? Okay, and you can see for vocal resonance, you can tell the patient to say one, one, or e, whatever, you can tell them, and just auscultate on both sides and comment on vocal resonance. So this is about the summary about the findings. What will you see in each condition regarding to the respiratory system? Okay, I hope this was clear to you. So next slide is abnormal interpretation of reduced chest wall on one side. If there is bilateral chest reduction, what would that indicate? So if it is just one side, it could be localized lung fibrosis, consolidation, collapse, pleural effusion, or pneumothorax. If it's all unilateral conditions. If it is bilateral reduction, it could be COPD or diffuse interstitial lung disease, right? If it is unilateral reduced chest excursions, it could be pleuritic chest pain or injuries such as rib fractures. Okay. Next is cardiac examination. So if you have time, you can go for the cardiac examination. If you don't have time, you can just try to cover up or be thorough with your respiratory examination, right? So in cardiac examination, you can just comment on central sinuses, any clubbing, and you can palpate for the pulses. Cardiac beat, if there's any peripheral edema, you can comment on that. You can also look for heart sounds or murmurs. At the end of the question, at the end of the examination, you can ask the patient has any question. Before that, you can summarize everything to the patient. Okay, make sure that you summarize everything to the patient so that you don't miss on any information, and then in the end, you should thank the patient. Okay. So next is, if you have, like I told, there could be a station with oral question, right, by the examiner. So if there is a station with oral questions, you will be asked question by the examiners, and you'll be given 3 minutes. Like I told initially, you should pay attention to what the examiner is saying. They'll tell you, okay, I'm going to ask you 3 questions, I'm going to ask you 4 questions. So you should be able to divide your time accordingly. Okay, and be very specific to them, like whatever questions they ask, be very specific. Don't waste time in telling a lot of things, because you're running out of time and they have 3 questions to ask you, right? So be careful about that. So now I'll be covering a little bit about what is pneumonia, what are the types of pneumonia, what risk factors, clinical manifestations, and management. So basically, the post-encounter